Good morning, everyone. I'm so happy to meet you again in this new project, The Great Rule of Advanced Critical Care Ultrasound in ICU. You will see in this case study the great rule of advanced critical care ultrasound in the midnight when your patient is gasping and you can know the diagnosis. A 47-year obese female patient not known to have any medical illness has undergone L4-5 laminectomy. Next day, while she was going to bathroom after surgery, successful surgery, she suddenly collapsed with severe respiratory distress, hypoxia, O2 saturation dropped to 77% of room air, hypotension 85/55. The RT team started noradrenaline IV and bolus of IV fluid was giving, blood pressure stabilized, but the patient, after stabilization of the blood pressure, she didn't wake up with right side hemiplegia. A major disastrous really in the midnight with the patient hypoxic, shocked, comatose, really a major disastrous. What is the differential diagnosis? It could be acute pulmonary embolism. Patient is obese after spinal cord surgery, very high incidence of pulmonary embolism. It could be bleeding, leading to hypotension. It could be neurogenic. She did spinal surgery. We started critical care ultrasound in this patient. First, the inferior vena cava is elephant inferior vena cava is markedly dilated. If you see the inferior vena cava is too much dilated, you can in this patient make the bleeding low in the list. Bleeding cause of this hypotension is low in the list, and you need to think about obstructive causes like pulmonary embolism and could be neurogenic. We did the parasternal long axis view. You see here, this is the long axis parasternal view. The right ventricle here is ballooning and compressing the left ventricle. This is the right ventricle and this is the compressed left ventricle. This is the aortic valve, this is the mitral valve, and the patient is dyspneic. We did subcostal view. Here the right side is dilated, and also the interatrial septum here you shifted to the left side, ballooning of the right atrium here with shifting of the interatrial septum denoting right side dilatation. For a chamber view, also right side dilated, compressing the left side. Short axis parasternal short axis view, flattening of the septum and ballooning of the right side here, compressing the left side. We did TAPSI here because the patient is obese and the machine is not so good. TAPSI here is low, it's less than 17, right side dilatation. Okay, we are facing patient now. Obese patient after spinal surgery, complain of acute sudden onset of hypotension, hypoxia, low MAPSI, dilated right side. That means it's acute core pulmonale. Dilated right side, compressing left side with low decreased TAPSI. That means it's acute core pulmonale. So here pulmonary embolism is high on the list really. And to confirm bedside, because this patient may not go to the CT at this acute event, so you need to do really in this patient what's called 60-60 signs, which is specific for pulmonary embolism, acute pulmonary embolism. The first 60 is the pulmonary artery systolic pressure in patient with acute pulmonary embolism will be less than 60 millimeter mercury, because in acute core pulmonale and the sudden pressure overload, right side will not tolerate this pressure overload and will fail and will not be able to generate pressure and increase the pulmonary artery systolic pressure. So you will expect pulmonary artery systolic pressure in acute pulmonary embolism less than 60 millimeter mercury, in contrast to the chronic cor pulmonale, which the right ventricle has time to build up the muscles of the right side and can generate high pressure. And in our patient, pulmonary artery systolic pressure is less than 60, it's 38 millimeter mercury. This is the first 60 in 60 sign. The second 60, you will get it from the parasternal short axis view at the level of great vessels. This is the aorta and this is the pulmonary trunk. You will put the pulsed wave Doppler here as the pulmonary trunk to look for the pulmonary artery flow. You will see here what's called the acceleration time, the time from the beginning of the pulmonary flow to the peak here. In case of acute cor pulmonale due to pulmonary embolism, this time would be very quick, very short, will be less than 60 milliseconds. In our patient, it's 60 milliseconds here. And you will see also what's called notched flow of the pulmonary artery flow. And you see the pulmonary artery flow here is below the baseline because away from my probe here. So in our patient, the 60 sign is positive. In the pulmonary arterial pressure less than 60 millimeter mercury, and the pulmonary flow acceleration time is less than 60 milliseconds. And a lot of articles talk about these 66 signs as a specific sign for acute pulmonary embolism. This large study on 511 patients also document that 66 signs is specific for pulmonary embolism. But unfortunately, it's not sensitive. It will not appear in all patients. But if appear, it is a specific sign. Okay. Also, you need to check the wall of right ventricle in the patient with acute cor pulmonale to confirm it is acute, because in chronic, the wall will be thick, but in our patient, the wall is 5 millimeter mercury, which is normal. So our patient has really a classic picture of acute pulmonary embolism with acute cor pulmonale, thin right ventricle, dilated right ventricle, positive 66 signs, and it is straightforward. And it is hypotension and hypoxia. Really, it is a full meal of acute pulmonary embolism. In acute pulmonary embolism, it is a type of obstructive shock. So, if you obstruct the blood flow from the right side, so you will expect left side flow to be low. And as we see here, if you put the pulsed wave Doppler here at the tip of mitral valve, you will expect low flow because this obstruction, and we get here grade 1 diastolic dysfunction with very low E wave compared to A wave, and very low E wave here is 41 centimeter per second. This is grade 1 diastolic dysfunction with normal left atrial pressure, and this is expected in pulmonary embolism. You will see obstructed flow to the right side, but low flow in the left side, and low flow also in the aorta. So you expect very low VTI here, but because of troops, it is 20, but stroke volume is low here, it's 55 milli. We did ejection fraction. It's okay, ejection fraction, because the problem is not in the left ventricle, it's obstructive shock, but you see the thick wall left ventricle, and this patient really is hypertensive, and he is not treated for hypertension, and she is obese, and this all risk factor for pulmonary embolism. As you see here from 2019 guidelines of acute pulmonary embolism of European Society of Cardiology, all the signs here in echocardiography are present in our patient. Right ventricle was dilated in long axis parasternal view, in four chamber view, and there is D-shaped left ventricle with ballooning right side. There is dilated inferior vena cava, and six signs here. Our patient pulmonary artery systolic acceleration time is very quick, and there is no notched flow, and also the pulmonary artery systolic pressure is low. 66 signs is positive. There is no thrombus, but there is very low function of the right side by low MAPC in our patient. So all signs of pulmonary embolism are present in our patient. Acute coronary pneumonia due to most probably acute pulmonary embolism. We did after stabilization يعني for the patient after stabilization we did CTP pulmonary angio. This is the aortic arch, and as you see the pulmonary trunk, there is pulmonary embolism everywhere in the main branches of the pulmonary artery. You see here there is in the main branches there is pulmonary embolism in our patient. Okay. But what's causing right side hemiplegia and coma? Patient has acute pulmonary embolism with acute obstructive shock, hypotension, hypoxia. But after stabilization, improving of the blood pressure, our patient has right side hemiplegia and coma. It could be stroke, it could be watershed infarction from shock. So, advanced critical care ultrasound at the midnight is very important. We did TCCD in our patient, and as you see, this is the temporal view. Here I am the left temporal window. Here is the butterfly hypoechoic midbrain, which should be, you should see this midbrain before commenting on the TCCD. This is the butterfly midbrain, heart-shaped midbrain. I'm here in the left side, I'm here in the right side. Too much blood flow in the right side and no flow in the left side at all. You see here, this is the posterior cerebral artery. Posterior cerebral artery, here is the left, and here is the right, and here is the left, and there is increased flow in the left, and here is the the right side. I'm here in the right side, no left side flow at all. Here, left side, you see, this is the anterior cerebral artery coming towards my probe, here in red, and here is the right side middle cerebral artery away from my probe in the blue color, and here is the right side posterior cerebral artery away from my probe in blue, and left side posterior cerebral artery towards my probe in the right. So I saw the only vessel which I can see in this TCCD in the temporal window is the left posterior cerebral artery, but I didn't see any left or left anterior cerebral artery or middle cerebral artery. I didn't see any flow in the anterior circulation in the left side, left anterior cerebral artery and left middle cerebral artery. In stabilization also we did CT with this is a cord sign with occlusion of the middle cerebral artery, and you see starting edema and hypo density in the left side compared to the right side. You see here left side hypo dense area compared to the right side. Here start evolving left side hypodensity in the all the left side really compared to the right side. We did the TCCD on the posterior circulation from the suboccipital window here. It's very good flow in the posterior circulation. The problem is not in the posterior circulation at all. Here is the left vertebral artery away from my probe, flow away from my probe in blue. Here is the right vertebral artery, good flow. Here is the pica in the left and the pica in the right. Here is the basilar artery, and even the anterior inferior cerebellar artery appear from the basilar artery. Very good flow in the posterior circulation, but no flow in the left side middle cerebral and anterior cerebral artery. And very good flow in the right side, very good flow on the right side. But what is the mechanism of sudden onset of acute pulmonary embolism and acute massive stroke at the same moment? It's a very unique event really. Pulmonary embolism happened with the acute stroke. It's not a watershed infarction, because watershed infarction will not cause arrested flow in the left and right, left, middle and anterior cerebral artery. It is stroke. But what's the mechanism of stroke? You need to do bubble test at the midnight. Very easy. Flush the agitated saline. Here will go to the vein, will go to the right side, and you will see the flow in the left side. That means this massive pulmonary embolism in the right side, which make pressure overload of the right side, it opens the patent foramen ovale and make the right to left shunt, which is causing more hypoxia and then causing also the stroke. Okay, how can you confirm this also? Okay, look, when you agitate the saline and inject the agitated saline in the basilic vein, the agitated saline will go to the right side and will go to the lung, and in the lung the bubble molecules will be absorbed and will not go back to the left side, so you will not see any agitated saline in the left side. Okay, if you put the pulsed wave Doppler in TCCD at the here I am putting not in the left, I am putting on the right middle. This is the midbrain and this is the right middle cerebral artery because the flow in the right side. Okay, I will put the pulsed wave Doppler here on the TCCD in the middle, in the right middle cerebral artery, and will inject agitated saline. This agitated saline, suppose, will not reach to the left side, so I will not see any flow, any bubble, any air bubble in the right middle cerebral artery. If I see any air bubble in the right middle cerebral artery, that means there is a right to left shunt. Okay, this is the normal flow of the middle cerebral artery. After injecting the agitated saline, see the high signal of the air bubble. This is the high signal of the air bubble. Very easy to see compared to the air bubble in the echo, in the fourth chamber. You see normal flow, and this is the agitated flow or high signal flow of the air bubble. So I document right to left shunt here as a cause of paradoxical emboli to the left side and the massive stroke in our patient. A lot of articles talk about the sensitivity and the specificity of transcranial Doppler, TCCD, compared to the transesophageal echo, and it is really gold standard in diagnosing right to left shunt. In our patient, we didn't see any pulmonary embolism, any DVT really. All the impulse reached to the lung and the brain, unfortunately. So, patient has left side massive stroke due to left internal carotid occlusion. Neurosurgery team cannot start thrombolytic after spinal surgery. Patient was unfit for thrombus removal. We was concerning of the consequence of massive stroke, which is brain edema. We repeat CT after 20 hours. Really, it was horrible CT. Horrible CT. You see very bad brain edema and the midline shift. Very bad brain edema because it's massive stroke really. Urgent left side decompression craniectomy was done for our patient, and we did, after stabilization, we did the stabilization here after aortic angiography. You see, this is the aortic arch. Follow the aortic arch here. You see, this is the aortic arch. I am going up. This is the nominant. This is the left subclavian. It's left carotid. I am going with left carotid here. Left carotid. Look, I did it in another view here. The left common carotid, when divide to the left external and left internal, you see left external is bigger than left internal and start to give branches here, and after that it vanish, completely obstructed this left carotid because of the thrombus. Thank you for watching. And in our project, very simply, you see the great power of advanced critical care ultrasound in the midnight in a patient with triple attack of the shock, hypoxia, and the coma, and you can get really a lot of information in very short time. Because of that, advanced critical care ultrasound should be it is a must in critical care area and should be used and mastered by anyone who need to increase her level of management. And thank you, and see you in another project soon, inshallah. Bye bye.